Good afternoon, ladies and gentlemen, and welcome to the 2019 Retrospective and Trends in Medication Management webinar presented to you today by TELUS Health. My name is Mike Bigg. For those of you who haven't met, I'm an account executive with TELUS Health, working specifically with the TPA market in Canada. I'm going to be your moderator for today. I've had the pleasure of meeting and even working with some of you already, and for others, this is our first interaction. So either way, delighted to have you with us today, and hope that you'll enjoy this presentation. These are the gentlemen that are going to be speaking with us today. Joining us from TELUS Health are Sean O'Brien, our Principal of Data Enablement and Product Roadmap, and Jason Kennedy, who's our Director of Health Business Consulting. They're going to take us through our 90-minute agenda. So for the next 90 minutes, we'll take you through a 2019 retrospective, reviewing drug data trends and national benchmarks, followed by a case study examining trends in medication management, and finally an overview of trends in product listing agreements. We have a lot of great information to share, so not a lot of time to do it. So without further ado, I'm pleased to introduce today's first speaker, Sean O'Brien. Sean, please go ahead.
Thanks, Mike. So very happy to be here, guys. Some of you I know in past lives, we've crossed paths. Several of you I don't know, but looking forward to interacting whenever we get the chance where we're allowed to actually see people in person, not virtually anymore. So I have about a half hour, 35 minutes. What we're going to do is go through, review our 2019 data. We're going to compare prior years where appropriate. We're going to touch on some key results, utilization by drug type. We'll look into our specialty drug analysis, followed by our book of business rankings. And then we're going to end off with reviewing some of the trends we're seeing in plan design across our book of business. So just to level set, I think our industry is notorious for having different terms for different things. So often insured, certificate, cardholder, claimant, plan member are used interchangeably. So for purposes of this session, insured will be the total number of distinct individuals covered during a period. And that's regardless of if they've claimed or not, regardless of if they're employee, spouse, or dependent. So basically someone covered. A certificate is one count that rolls up all, covers an employees and all their linked dependents. So basically a family would be counted as one. One other thing we're going to focus on for the most part is eligible costs. We do that to really neutralize plan design differences. So the majority of the analysis will focus on eligible. So the cost of the plan paid before any design features like coinsurance and deductible. So another thing to note is the numbers I'm going to present are going to probably differ significantly from certain individual plans you manage or administer. Things like the coverage level of the plan, demographic composition, provincial program coordination, and even industry can impact costs. So keep that in mind when you're drawing some comparisons between these numbers and what you may see across your book. And with respect to trend, our analysis will always reflect lower trend than is used in insurance plan renewals, as you probably all know. The trend used in renewals is forward-looking to provide a projection of potential costs across the next 12 months. It's usually fairly conservative. Our data is looking at actual year-over-year change from 2018 to 2019. So renewal trend obviously takes into other things too, experience of the group, demographic aging, insurers' manual rates, and also will include extended health medical claims in the trend factors as well. The types of drugs we are looking at, just to give you clarification on what those are. Single source drugs, obviously a drug where there is no generic, so a brand drug. A multi-source brand, it is a brand drug that was dispensed, but there could have been a lower cost generic equivalent dispensed. And then generics are obviously it's the copy, the bioequivalent copy of the originator brand. We are going to talk about biosimilar drugs today as well. Those, as you know, are not the same as generic to brand. So for the most part, we're focusing on insureds under age 65 because we're looking more at active employee plans. But given OHIP Plus, we will be looking at when we're doing comparisons across provinces or regions, we're going to be looking a lot at the 25 to 64. So This is the third time that because of the, OHIP Plus was implemented, then it was repealed. Each year it seems we need to look at different cohorts to make meaningful comparisons. Just to give a level set of our book of business, our book of business has been increasing outside of Ontario actually at a greater rate than within Ontario. So the 4.8% versus the 1.5% growth in Ontario. Then we've gone up 3.4% growth in certificates nationally. When we look at the total insured, we cover nearly 13 million Canadians, and we process over 150 million drug transactions annually. So I'm going to get into the key results section now. So you'll see here I'm looking at 25 to 64, and again, that's because we're showing some comparisons by region, and we're trying to strip out what's happened with OHIP Plus over the past year. So across Canada, our average eligible monthly cost per insured was $54.01. The monthly eligible cost per insured is lowest in the West at $40.85. Most of that is given, pharmacare in many of those provinces that we consider in the West. So that's keeping costs down. The average eligible cost in Ontario is the highest at $85.72. Well, it's the lowest in Quebec at $61.22. But as you know, utilization rates obviously higher in Quebec because they're dispensing a 30-day supply, even for chronic medications for the most part. So they're not, their cost per claims are lower, but their person's making more trips to the pharmacy. So their utilization is much higher. When we look at generic fill rates, Atlantic Canada has the highest region, hitting 70% of all claims. So this is the first time we've seen across any region 70% generic penetration. So 7 out of 10 claims are filled for generic. However, it's not really reflected in the cost per claim. As you can see, their cost per claim is very, very high. It's just shy of what it is in Ontario. You'll see later, Atlantic Canada continues to have the highest percentage of specialty drug consumption. So really, that's what's driving their high cost per claim. So even though only 30% of their scripts are for drugs that aren't generic, the majority of them are for specialty. Okay, so this is 0 to 64, just to show impact of OHIP Plus. So when I look at the slide, to me it looks like Ontario's given the middle finger to the rest of the country, because all of a sudden OHIP Plus is repealed again, and now in April of 2019, and then we see even though it wasn't a full year in these numbers, a significant increase in eligible monthly cost because of private plans becoming primary payer once again. So even given the significant volume Ontario represents as a portion of Canada, the impact of the change of OHIP Plus is felt on a national basis. As you can see here, Canada eligible monthly costs has gone up 7.6%, and that's a big part of the OHIP Plus in the jump in Ontario, 10.2%, just given the concentration of claimants across the book of business in Ontario. So you also see the average age of employee has remained relatively stable, so that's not a material factor at all in the changes in cost. So after these slides, we're going to start looking at the 25 to 64 just to provide more meaningful comparisons. So if we look at those aged 25 to 64, we see that the cost per claim increased across all regions, netting out to 3.3% increase year over year in Canada. As you're going to see in later slides, increases in specialty drug utilization is adding to cost pressures across all regions, again, most notably in the Atlantic Canada, given its much higher percentage of specialty drug costs. So overall, on a national level, the change in utilization was 1.7% increase. It did vary quite a bit by region. As you can see, there was even a reduction in utilization in Atlantic Canada. Okay, so the gray numbers that we've left on the top here, those were the numbers if we were looking at 0 to 64. But we're looking at 25 to 64. You can see the contrast in the purple numbers when we strip that out. So Ontario's grown at a much more moderate rate at 5.4%. But if you keep the under 25 cohort in, it's 10.2%. So almost double because of that. So just to unpack the components of trend, we saw on the prior slide that the overall trend went up 5.1% across Canada. However, when you split that out between traditional and non-traditional, we're seeing 10.1 specialty drug spending increase year over year versus 2.9% for traditional drugs. So again, as you'll see in later slides, it's still a very, very small percentage of claimants that are driving overall plan costs with specialty drugs, but it's getting up to 30% of our total book of business costs. So looking at the different components of trend across different drug types, we see here that, let me try my pointer. So really it's the average cost per claim overall that has been driving that 5.1% increase. Yet if you look at specialty drugs, it's really the utilization has gone up. So we see the utilization of specialty drugs increasing far more quicker than than traditional drugs. So there are newer, more novel therapies coming to market. They're treating previously undertreated or untreated diseases. Knowing what's in the pipeline, we will see increased utilization of all these breakthrough products moving forward. So looking at age, as expected, costs per insured increase as we age. Yeah, very, very startling, right? But the younger individuals are typically claiming acute therapies, antibiotics or things like that are, one and done, very, very low cost. So they don't cost a lot in the plan. Many of the younger kids aren't even, going to see their physician, so they're not getting prescriptions. But as we age, we're seeing chronic conditions becoming much more prevalent. So, sorry, I got back. It's not uncommon for someone in their 50s and 60s to be on several medications at once to treat a variety of conditions. So if I think of type 2 diabetes patients, often they're on a diabetic drug, but also often on other drugs to treat the comorbid conditions that go with that. So hypertension, elevated cholesterol, could be mental health, could be pain management. Jason will go into a little bit more of this when he talks about the journey of a diabetic patient. So if we look at age more closely, when we bring back in the under 25 age cohort, we see that it had the highest cost increase over last year. Again, really that's because the private plans in April of 2019 became the primary payer for that age group again. So if we look at the others, though, we are seeing the highest cost beyond that in the 25 to 29 age band. But if you recall the previous slide, that age group is relatively low cost compared to the older age groups. The oldest age band witnessed the lowest cost growth, the 60 to 64. But again, if you look at the prior slide, that is certainly the highest, the most costliest age band under the private plan. So even that small percentage growth can be significant. So the next section is going to talk about utilization of different types of drugs. So either generic versus brand, specialty versus traditional. We'll also look at biosimilar. So from the key results slide, you'll recall our generic fill rate for 2019 across Canada was 63%. Again, Atlantic Canada has the highest generic utilization at 70%. Ontario had the lowest with just over 6 out of 10 claims being filled for a generic drug. So overall, we are still far below the generic penetration rates of the United States that are in the mid-80s range, given more multi-tiered formularies that promote preferred drug product utilization in those down in the U.S. compared to here. The percentage of multi-source brand drugs, so multi-source again is a brand drug that had a generic, had an interchangeable generic equivalent on the market, is highest in Quebec at 8%. This is despite a 1% increase in generic utilization you saw on the prior slide. But there's certainly a reduction in single source brand drug utilization as well under this group, under Quebec. So Quebec, you can see, had by far the steepest decline in multi-source brand utilization over recent years, much of that to do with the generic substitution policy changes implemented in 2015. So keep in mind that these statistics are based on the drug that was dispensed. So there are the plans that have more rigorous mandatory generic substitution plan design would have only paid up to the generic equivalent price, even though the brand was dispensed. So when we look at the number of claims perspective across Canada each year, we see very slow increases in utilization for generic drugs, and obviously the corresponding reductions in brand drugs, whether it be multi-source or single source. So we're now at 63% in 2019 versus 58% 5 years ago. So not going up significantly. Have we plateaued? Not sure. I mean, most plans do have a mandatory generic substitution in effect, so it'll remain to be seen how low, or sorry, how high that generic penetration rate can be driven. Now, if we're looking at the drug type by cost, single source brand drugs continue to dominate the percentage of overall eligible amount paid, now reaching 70% of total plan costs. This is largely driven by the significant costs for specialty medications, as we're going to see in some of the following slides. So we are seeing new specialty medications that will reach a broader patient population. They're going to treat more chronic diseases, where before it used to be, more rare disease. So that will drive the single source brand category upward. What remains to be seen is when the proposed PMPRB changes go into effect, which is now expected to be January 1st, 2021, what type of downward pressure will that have on patented brand drug costs? So generics, although very, very highly utilized, account for only a quarter of our total eligible costs nationally. So the next few slides are focusing on specialty and biosimilar drugs. Definition of specialty drug, there is really no standard industry definition of what a specialty drug is. Most PBMs and insurers would consider any drug that has an annual treatment cost of over $10,000 a year to be considered specialty. They're not always biologics. It could be a small molecule drug that has a very, very high cost. They do typically require special handling and administration, could be injections, infusions, and they're treating more complex diseases for sure. So while the percentage of claimants remains relatively flat year over year, we're now seeing 30% of total costs attributed to specialty drugs. So it's always hovered around that 1% of claimants, but now it's generating 30% of total costs. So really, there's not a huge increase in utilization per se, but there is, I think the higher cost specialty drugs are definitely driving the overall plan costs up. If we look at a regional basis, as I said earlier, Atlantic Canada has the highest percentage of specialty drug costs, and it's given there's some higher prevalence of rare disease and genetic disorders in that region. If we look back at 2008, Atlantic Canada has increased over 3 times in that 10-year period. The Western provinces continue to see lower specialty drug costs, really again given provincial pharmacare programs are paying much of the cost in those different areas. The monthly cost per certificate for all drugs is now $94. This has increased by an average of 1.9% per year over this 11-year period I'm showing. So not huge increase per annum for all drugs combined. But if we start looking at the different types of drugs, non-specialty drugs actually showing negative growth over the 11-year period. So averaging a reduction of 0.6% each year, with the monthly cost per certificate now $66, and it was $70 back in 2008. So a lot of that has to do with the generic pricing legislation over this 10-year period where we saw provincial pricing reform come into effect and lowering cost of generics by each province. So to demonstrate the impact of specialty drug products over the years, the cost of these drugs are growing at a much faster rate than traditional drugs, increasing on average nearly 13% each year over the past 11-year period. So if we project that forward, using the same historical growth rates, specialty drug costs per certificate could be as high as $55 in 2025. So it doesn't seem like a lot of $55, but that is the cost of all certificates. And we know that only just over 1% of claimants are contributing to the specialty drug costs. And then if we look at total costs, given the growth in specialty drugs, total monthly cost per certificate in 2025 for all drugs combined would be $119. So that's an increase of 26% over the $94 that we saw in 2019. So is that sustainable? It's going to create a whole new set of challenges in controlling costs for plans. So I'm focusing on these 7 drug categories because you'll see in a later slide when we look at our top 10 rankings, these are the top 7. And what we wanted to do is show, what's driving them. Is it specialty versus traditional? So you can see the RA category is almost 100% made up of specialty drug costs. In contrast with diabetes, it's the opposite. So there aren't any real specialty drugs when we consider something to be over $10,000 per year in the diabetic drug class. But there are these newer, more costlier drug therapies, incretin mimetics, DPP-4 inhibitors, SGLT2 inhibitors, the very new class of drugs that are driving the cost. So we're starting to see about 2/3 of total diabetic drug costs coming from these newer classes of drugs. Also, when we're thinking about how much more widespread utilization is for those people getting diagnosed with type 2 diabetes or pre-diabetes, we're seeing this class growing for sure. The cancer class is also seeing higher concentration of specialty drugs given the new advances in this area. And we also know that in the pipeline there's several drugs coming to market to treat various cancers. So we saw in the drug trends slide that specialty drug costs increased 10.1% nationally. Of note, Atlantic Canada had the highest percentage of specialty drug costs, and we see that it has increased the most year over year as well. Traditional drug costs have been flat in Atlantic Canada. Ontario has similar growth profile to the national numbers. We wanted to look at adherence rates across different chronic conditions. So we calculated adherence by using a measurement called the medication possession ratio. So what that does is we look at a chronic drug and an individual on a longitudinal basis and look at the time between, look at the days supplies dispensed and the time till they filled their next claim. So we consider anybody with an MPR, medication possession ratio, of less than 0.8 to be non-adherent. So just to give you an example, if a person had a prescription for a drug dispensed for 90 days supply, but they never filled it, the next prescription till about 115 days, that would get you about a 0.8 adherence rate. So we would consider that person non-adherent. So taking drugs on time and as prescribed is critical in managing most of these diseases. If you think of antidepressants, often people start to feel better and they will skip doses. Diabetes is a very, very complex disease to manage, and adherence is very important. Jason will share some more insightful details on this when he's up next. I look at asthma, it's very high non-adherence. But when you think about it, asthma has a very seasonal component. So you may have people that filled, Singulair in the spring, and it was dispensed for a 30-day supply, but then they don't need it until maybe the fall when their allergies are more, or asthma is more prevalent. So The next couple of slides are going to focus on biosimilar adoption. We're focused on BC in this instance because of that province implemented initiative in 2019 to switch patients using the originator biologic drugs. Depending on their indication, they'd switch them to the biosimilar versions that are much lower cost. So again, that initiative applies to the public sector, but we are seeing increased adoption based on these are new patient starts. So in this case, Basaglar is the biosimilar, and you can see at September of 2019, it starts to surpass Lantus, which was the innovator biologic drug. So perhaps the public initiative is influencing physician prescribing because there haven't been many private plans adopt any kind of switching policies as of yet. Similarly, here we're looking at Remicade, which has been the highest cost drug under plans for years now. We are seeing a flattening of Remicade new starts, and in this case, there are two biosimilars on the market. Inflector was on the longest, and you can see it's surpassed new starts of Remicade, and then Renflexis was later to market, and it's starting to show some increased adoption as well. I'm going to look at the top 10 drug classes by eligible amount. Not seeing much of a change year over year in the top 10 classes. In fact, the top 6 remain unchanged from last year. There is some flip-flopping between the 7 to 9 ranks. But when you think of the top 10, 5 of these could be considered modifiable risk. So what I mean by that is that there is other lifestyle factors that could be contributing to these diseases. So diabetes, if it's type 2, not type 1. Asthma, that does include COPD, so that could be based on lifestyle habits. Depression, certainly. Some forms of cancer could be lifestyle-based, and blood pressure, absolutely. We're looking at the trade names here to show their rankings. Again, not much change year over year. The biggest exception you see is the Freestyle Libre. It's gone from 40 rank last year to number 7. So it seems, jumped ahead. It seems that, you know, the convenience factor of having your levels monitored automatically and electronically, you don't need to use lancets and test strips. So something like that seems to be driving the adoption of this particular product, and it's believed to create better compliance. So I'm going to finish off with plan design in the next few slides. When we look at our book of business, the plan design data, 87% of all insureds fall under a plan that has some form of generic substitution. So either what we're calling regular or mandatory. So this is a 1% increase from last year. So the difference between these two substitution types is whether you allow the physician to override by putting dispensed as written or do not substitute on the claim. So the regular form, if the physician writes do not sub, the plan will pay the brand, will dispense the brand and pay it at the brand price. But the more mandatory generic form, even if the physician writes that, the plan will still only pay up to the generic price. There are certainly exceptions if medical evidence can be submitted, but it takes the control out of the physician to basically just say, you know, dispense the brand. So we're also seeing that split between what we're calling regular and mandatory, certainly evolving more towards mandatory generic substitution. So that's gone from 53% last year to 56% of insureds. Not much change in coinsurance when looking at 2019 over 2015. We see a slight decrease in the number of certificates covered under a plan that has 100% reimbursement. Most of that shift's gone to 80%, where we're seeing a 3% uptick there. So we are seeing certainly more and more plans looking to contain costs by sharing plan costs with their members, having their member pay a portion Also helps them see the value that the plan sponsor is paying on their behalf and makes them become better consumers, given they have a choice in product selection. Annual maximums, growing since 2015, but still only about 20% of our certificates are covered under a plan that has an overall annual drug maximum. We have started to see that in recent years, but mostly more around smaller plans, because when you think about a small plan, you know, 1 or 2 people on a specialty drug can be very, very catastrophic. So it's not sustainable. So many of them had no choice but to put in, you know, an annual maximum. From a deductible standpoint, we're certainly seeing fewer plans having any form of deductible, whether it be annual or per prescription. So now only 23%. Annual deductibles have historically been very, very low, and they don't make a meaningful impact on containing or sharing costs. When you think of, you know, the old 25, 50 single family or even 50, 100, most of those deductibles are satisfied within the first, you know, 1 or 2 claims of the year. So they really don't do much beyond that. So we're seeing more of a trend towards adopting a percentage-based coinsurance in favor of a fixed deductible, because obviously the coinsurance moves with inflation. If I look at plans that have a per script deductible, it's typically either $5 or $2 are the most common. So dispensing fee caps, plans that have a cap have followed a similar distribution since when we look back at 2015. However, there's still about 70% of certificates that are covered under a plan without any dispensing fee cap. Dispensing fee caps are a good way to incentivize members to shop around to save out-of-pocket costs, or they can pay out-of-pocket if they want. If convenience means that much to them, they can go to the pharmacy of their choice, but the plan's going to cap obviously at what's considered reasonable. So it is interesting that there hasn't been a lot of adoption in this area, given pharmacy dispensing fees in some pharmacies, when you think of like Costco and grocery stores, are much, much lower than the bigger pharmacy chains. From formulary type, by and large, the vast majority of certificates are covered under an open formulary. So what that means is, you know, when the drug gets approved by Health Canada, it's prescription requiring, it lands on the formulary. But keep a note, open formularies do still have other types of restrictions. So often our open formularies will have lifestyle classes that have either maximums or exclusions, and certainly prior authorization will still apply to open formularies as well. So we're seeing a very low progression, slow progression, I guess, towards managed formularies. Although again, in the U.S., these are the norm, 2, 3, 4-tier formularies. We don't see a lot of provincial mimic plans simply because they're very, very restrictive and are limited access to many drugs. Again, looking at prior authorization, we're seeing a reduction in certificates when we look back, that are using some form of prior authorization. So what that's from is, I mean, several years ago when prior authorization came out, there was a focus on a lot more products. So drugs like the proton pump inhibitor class, for example, lower cost, but there were other drugs that were cheaper, and there are other drugs that could have been more first-line therapy. But we've seen a shift away from that, where the focus is now more on truly on those higher cost drugs. So fewer certificates covered under plans, but it's a mechanism now to look at the very, very high cost drugs. Okay, so in summary, the monthly eligible amount per insured saw a 5.1% increase over last year. That was based slightly more on the change in average cost per claim than on increased utilization, as we showed. Plan members with concentration in Ontario would have seen an increase in cost year over year for sure, given the repeal of OHIP Plus back in April 2019. Specialty drug costs continue to rise, trending 10.1% in monthly cost per insured year over year. Adherence could certainly be improved across several chronic conditions, which could have a positive impact on treatment outcomes. we saw slow progression in plan design features to contain costs, as I just gone through those. But I do believe we're going to start to see things like product listing agreements, certain different biosimilar strategies, high-cost claimant management, chronic disease management. These are going to start to emerge. Jason is going to touch on some of those in the presentation next. So with that, I will open it up to some questions.
That's great. Thanks very much, Sean. Just had one question come in through the chat box, so we'll address that first if we could. And it was regarding the average spend per certificate as it relates to specialty drug. You said it was $55 per cert, which was actually lower than the non-specialty drug spend per certificate. Now, is that because what we're doing is taking the total of all specialty drug spend and spreading it over sort of a per capita, so spread over all certificates?
Yes, that's correct. So it is spreading that cost over all certificates, yet knowing that it's only about 1% of claimants that are driving those types of claims. So on a per certificate level, it's $55, but that is significant at a certificate level because, again, really only about 1% of claimants are contributing to that overall cost, which nets out to $55 per certificate.
Great, thank you. If you do have if there are other questions on the line, you can please press *9, or actually I'll press *9 to unmute all the lines right now. And if you have a question for Sean, then feel free to ask now. And Mike, did that answer your question about the average spend per cert?
La conférence n'est plus en mode présentation.
There we go. Sorry. Yeah, it did. Thank you. Okay, great. Any other questions for Sean? Okay. You're getting off light here, Sean. So again,
maybe
thanks very
someone
much.
Come up after.
Yeah, that usually happens. So if any questions do come up as we're going through Jason's presentation, again, please feel free to enter any questions you have in the chat box on the side of your screen, and we'll try to address those throughout. And if not, then we'll certainly touch base again at the end of the presentation. Okay, so with that, we'll pass things over to Jason Kennedy. Jason, you can take it away. Thank you.
Thanks, Mike. Did you want to throw us back on presentation mode?
Absolutely, I do.
La conférence est maintenant en mode présentation.
Thank you to everyone on the line here today for allowing us to present to you. Over the next 30 minutes or so, I'm going to take you through two different presentations. This first one is our trends in medication management regarding diabetes, and then I have 3 or 4 slides to touch on some of the changing dynamics legislatively and otherwise that are impacting PLAs in the event you find it topical. As with Sean's presentation, there's the standard housekeeping applies that he's shared in terms of the way we reference. The key piece here, I would say, is in this case, I'm only using less than 65. In this case, I don't deviate from that at 65 years and under. This slide here you would have just seen in Sean's presentation. I like it because I find that it grounds us in what I'm about to show, but also I like it because the pharmacist part of me, I look to different diseases and I try and understand how do these relate to one another. In other words, what crossover exists at the claimant level? These are, describing the costs within the diabetes categories. But I really set out with the idea of looking to a view of what the member looks like. Theoretically, a member who's on diabetes medication is on other medications. And so how does that contribute to some of these other disease state or therapeutic class areas? So I set out with a mission to really try and better understand what this diabetic member could look like from a claims perspective. And I've called it a portrait of a diabetic. And during this presentation, I'm aiming to answer the following questions. What does an average diabetic look like? How did their medication regimen contribute to costs of this member? How does the category I just showed you cross over to other categories? And to understand the cost impact on our TELUS book of business. Just a quick level set on how this was done. Just real quick here, we extracted all the claimants from that diabetic category that made a single claim or more in 2019. Then, once we had all those individuals, we extracted all the paid claims for that list of individuals and organized this information in a way that we could round up the information at a claimant level. And that left me with a view of all those who've claimed a diabetic medication plus everything else. We did do some data cleansing here in this case, though. If you were only on one diabetic medication, we did strip you out. I mean, had one claim for a diabetic medication, we stripped you out just as it relates to, we thought that might be seen as noise here. So we wanted to just say if there was a mistaken claim or a one-time claim, just remove that. Adherence, you'll notice, is something that Sean touched on. I touch on it here as well. Really succinctly here, I think Sean did a great job just to refresh your memory. Essentially what it does is it measures the percent of time that a patient has access to a medication. So simply, if they don't have access to the medication, then they aren't taking it, and meaning, in that case, they're non-adherent. In the case of this presentation, we are assigning a medication possession ratio, or MPR figure, to each medication the member was on, and then we're averaging those to get one MPR value per member, and we're going to group that. And lastly, I think it's important just to be clear on this. This is a data level exercise, and in this case, it considers all diabetics as a homogeneous group. What we understand, though, is diabetes is a complex condition. There exists type 1, type 2, and gestational diabetes, each with slightly different epidemiology and causes. From a proportion point of view, type 1 make up about 5 to 10% of all diabetics, while type 2 take up to 90% of all diabetics, with gestational taking up somewhere in the vicinity of 15 to 30% of pregnant women only. That's a small figure. So from a representation point of view, we can kind of represent that this is largely going to be of a type 2 diabetic population, but the data itself is not homogeneous. So just some Coles notes to ground you here. This case, diabetes, is a complex condition. It's a condition where your body either can't produce insulin or properly use the insulin it produces. Insulin happens to be a hormone that is produced by the pancreas and signals the removal of sugar from the bloodstream. It's a progressive condition, meaning over time it advances, and managing the patient is really to manage A1C here, which is really a measure of how much sugar is in the bloodstream measured over a longitudinal 3-month period. Achieving optimum A1C is associated with better outcomes. So think of it as a long-term view of your blood sugar readings. From a risk factor point of view, and this is where going back to that initial slide is important, there are significant risk factors associated with the diagnosis of diabetes. First of all, you're high risk for cardiovascular events such as heart attack and stroke. Also high risk for microvascular events such as infection, which could lead to amputation due to blood flow issues, as well as kidney failure and blindness. And diabetes happens to be the #1 case and cause for these areas. So this begins to start to illustrate how this patient has claiming needs in other categories beyond the diabetic therapeutic class we showed that are really due to help address the risks or treat complications that can arise. And you know, this leads to the emergence of complex conditions, which is not meaning, it's not simply keeping blood sugars at target that are important, but other things such as ensuring aggressive cholesterol control and blood pressure targets are super important. Other elements that are important to understand, polypharmacy. In this case, it's the sense that within a therapeutic area, like blood pressure, cholesterol, or even the diabetic therapeutic area, that multiple drugs can be required to treat that therapeutic, that condition. So, you know, to get cholesterol under control, it might take 3 or 4 medications. To get blood pressure under control, it might take 3 or 4 medications. To get your blood sugars under control, it might take 3 or 4 medications. So you start to see how this starts to compound pretty quickly. There are defined treatment pathways and guidelines, which I'm about to show you. And also, you know, nicely and fortunately, there's has been a lot of innovation in this space in the last 5 years or so. But at the same time, these have also contributed to increasing costs in this area. This slide here was repurposed from diabetes.ca. They're formerly known as the Canadian Diabetes Association. And it's really for type 2 diabetes, okay? So type 2 only. It's very busy. There's a lot going on. You're going to have it as a leave behind here. But it's for illustration. And really, the take home is as follows. Metformin, which is a long genericized medication, and inexpensive therapy should be started first when you receive a diagnosis of diabetes. How quickly the member is able to get their sugars under control can dictate the speed to the next medication. That being said, it's not simply blood sugar readings that determine what the second and third medications are. It can be due to if they have comorbidities or risk factors for cardiovascular as well that determine what the selection of the second or third diabetic medication is. The real point and take home and so what of this is that there are step therapy regimens from a plan design point of view that can be helpful in ensuring that metformin goes first. That being said, after that, it gets individualized pretty quickly. So to be able to do a step therapy beyond that, automated is tricky. You can do it through prior authorization where you're asking what previous medications are, but to do it through a systematic approach is a challenge. So now that you've got the Coles notes on what diabetes is, why we're sitting here, why we're talking about it, and why I'm sharing all this with you, let's start building out what I call our portrait of a diabetic. And if you remember the first slide I showed you, in that case, we have those claimants that belong to the diabetic category. Once we've done all the cleansing and everything associated with it, 4.92% of all claimants on the book of business had more than one diabetic medication and are considered as part of this analysis. They had an average age of 50. If we keep this in view of other of the diabetes category, but also how it contributes to other categories, here's an initial view. So if we look on the bottom here, we see the number of claimants. We look on the y-axis here, it's the different therapeutic areas. In this case, we have almost 59 and 60% respectively of those claimants on a diabetic medication, also on a cholesterol or blood pressure medication. So again, when we see these therapeutic areas as our top 10, it's quite likely that some of that cost is being driven in both categories by the same patient or claimant. Other notable categories that you might see here are some of the modifiable ones that Sean referenced earlier, asthma medications, and those with medication for depression as well. You know, when we take this all together and look at our portrait of again, in this case, we see that this population of 4.92% of claimants are responsible for almost 18% of all claims. Again, that's just claims, not the cost in this case, and gives an idea of how this population contributes to costs in other categories from that initial slide I grounded you in at the beginning. And this is linking back to that medication possession ratio and how we've spoken about polypharmacy, which is the idea of multiple medications to treat a condition. In this case, what we've done here is we've done a count of the number of distinct medications a claimant is on during that 1 year period of 2019. And we've looked at measuring the average adherence of those members. And the real two key takeaways of this slide are, and it's not really surprising here, and it echoes what Sean has shared in his slides. The medication possession ratio, so that adherence ratio, is under 80 for this entire population, meaning this entire population on this slide here with 5 medications or more are essentially non-adherent as a population, which is kind of troubling. The other piece is to say that as you increase in the number of medications along the x-axis, understandably, your adherence goes down. So this is a problem, though, given what we know about the progression and what I've shared with you about risk factors. And, you know, it's not unlikely that you might get to multiple medications. But knowing that the adherence goes down as you get to those is a bit of a problem in that, you know, we know that medications don't work if you don't take them correctly. And in this case, you know, what does that really mean for outcomes if we're adding more medications, but, you know, as we continue to add them, they're being taken in a worse and worse fashion. So the average adherence for the entire population is 74%. The so what of that is that the average diabetic is on 7 medications, 7 unique medications. We look to distribute this, and this was an interesting data, I guess, happenstance. We didn't plan it this way. We didn't know it would look like this. We thought we might see a bimodal distribution. We saw an interesting bell curve shape here. And essentially what we're saying is the mean individual resides at 7 distinct medications. Go to this next slide here. I've broken it into 3 cohorts for the ease of identification and for further analysis. In this case, cohort A is, and this is completely arbitrary. In this case, cohort A is from 1 to 5. Cohort B is from 6 to 10 unique medications, and cohort C is 11 plus medications. In this case, like I said, it was just more for grouping so that the subsequent analysis here can be a little bit more intuitive. You could try and group this in any way you'd like, but I think the way we've grouped it here ends up blending itself nicely. So, you know, now that I've showed you that adherence goes down over time and the average number of medications is 7 unique medications that a diabetic claimant is on our book of business, how did these, oops, jumped the gun there. How do costs increase as the number of medications increase? And what are the contributors of those costs? So just to orient you real quick, purple in this case are strips and sensors. Gray are diabetic medications. And green is the sum of all total claims. So includes strips, sensors, and every other claim taken by these diabetic patients. So whether it's for blood pressure or cholesterol. And the take home here is that, interestingly enough, we thought this would be a bigger, we thought this would be a bigger contributor, but diabetic test strips and or the meds aren't the biggest drivers of cost for these members. In fact, the biggest driver ends up being everything else that is being claimed to manage this claimant, this member, this patient. And also what's interesting is once you hit around 12 medications here, you see that it's not unusual for the member to cross a threshold, this imaginary threshold of $5,000 annually in eligible costs. So they get pretty pricey, but the real driver of it is everything else due to the comorbidities and complexities. So now I've jumped to this slide twice, third time's the charm here, overlaying my cohorts against the spend just to help organize this a little bit. Cohort A you see with the lowest total cost because it maps against here. But things really start to escalate once you get to here, where you see that in this case, we have some really complex patients that are over $10,000 annually. That's not insignificant. And if we dig a little deeper into these cohorts to understand the meaning of all this, we look here and we see cohort A, those with 1 to 5 medications, are responsible for 34 or 35% of all diabetic claimants. They're eligible that they're responsible for is 17%, give or take. Cohort B, those on 6 to 10 medications, are responsible for 42% of claimants and about 40% of costs. So somewhat, proportional and linear in that fashion. Cohort C is where it gets a little interesting. We see 23%, so this is those on 11 or more medications. We see that there's 23% of members in this case, but they're driving or contributing 44% of costs. So this is pretty significant. It also indicates that once they get into this 11 plus cohort, they're a high utilizer group. And if we step back and try and say, what does this mean on average and on aggregate? The average diabetic claimant is $3,020 on the TELUS Book of Business. Meaning, if you were to do some forecasting, as Sean mentioned, that varies by your book. But in general, if you do some forecasting, this is what a diabetic will cost you on an average. Now, if you dig a little bit deeper to look at the different cohorts, cohort A, 1 to 5, is responsible for $1,400. Cohort B has an interesting doubling effect, going to $2,800. And then we double again, going to 11 plus medications, almost at $5,700. So again, this cohort 11 plus, their average is over $5,000 a year. And when you think about the fact that the average is on 7 or more medications, what does that trend look like in time? So something to think about. But to make matters worse here, it's this group that it costs the most that have the worst compliance and adherence. So these are not really productive costs. So if we come back to the overall portrait of what an average diabetic looks like here, like I mentioned, on average they're responsible for $3,000, give or take. The strips and medications for a diabetic, the diabetic medications, proper, are responsible for $1,500 of that. Of course, as you get into the higher cohorts, that shifts, like I mentioned. But on average, that's how you see the split. So half of the medication cost is coming from other areas outside of the diabetic therapeutic area. That's the cost of managing the claimant or managing the patient. Now, if we zoom out for a moment and we look at this 4.92% of claimants against the overall TELUS Book of Business, we see that these claimants are responsible for contributing about 18% of the total costs. And then if we look at cohort C, these are our high utilizers at 11 plus, they're responsible for 8% of the total costs. So if you think about it this way, we have almost 5% contributing to 18% of the costs. And then as a mind exercise, if you go back to what Sean mentioned, where we have the specialty category and less than 1% of claims, mind you, are responsible for 30% of costs. Essentially, you have in the ballpark of 6 or fewer percent claimants contributing almost 48% of costs. Now, this is non-exact. It's more of a thought exercise, but it gives you a sense of the magnitude of the two populations and their cost contributions. Now, thinking back to Sean's slide where we showed that the class was responsible for 10.6%, if we look at the entire claimant level, they're responsible for 18.8%. So again, what is that contribution to those other areas that we're seeing on the top 10? So the point is we can't look at this in silos, and these populations can't be managed in silos. So we add here the final elements of our portrait. We have an average diabetic who's 50 years old, typically on 7 medications, resulting in a cost of $3,200 annually, half of which is for diabetic medications. And from an adherence point of view, there's more than opportunity for improvement in adherence. So, you know, sharing all of this to kind of talk about and grouping it into cohorts to kind of talk about and allow you to consider, if we were to intervene, where would we intervene? And, you know, do you intervene at the highest cost cohort, or by then are they too far gone? Do you intervene at the earlier cohort, or will the volume overtake you? You know, right now we've got ample solutions from a cost containment point of view. And what I mean by that is, you know, there's a number of ways to approach appropriate use, whether that's managed formularies, which would encourage value for money, step therapy, prior authorization to ensure members are going through the appropriate first-line medications or have the comorbidities to qualify for some of these second or third line. There's mechanisms to manage waste in terms of dispense fee limits, blood glucose test strip limits, step therapy, both for the medications and the sensors. And then there's the opportunity to, you know, bend the cost curve and manage the unit cost, whether it's through PLAs or biosimilars. So there's ample cost containment. But, you know, what I've showed you is a portrait of a diabetic from a data point of view. This is really what a diabetic can look like. They can look like anyone. And what I haven't really talked about is, you know, it's clear that the cost containment that I just showed you are necessary. But in spite of those cost containment options, we're still seeing both a progression and increased cost. So what does that mean from the actual person? And so that's what I want to explore in the next few minutes here. So what about the member, really? So the key themes in this case, healthy behavior interventions, and this is from diabetes.ca. This is publicly available. It's not my IP. Healthy behavior interventions should be initiated in newly diagnosed type 2 diabetes. When and how? You know, in the form of education and lifestyle, in the form of behavioral modification through wellness, adherence, and persistence. Prevention is probably the best course of action. So that's something we want to think about here as well. And if you happen to see our conference with Dr. Brendan Byrne, he talks a little bit about that as well, through diet, lifestyle, and intervening really early before you actually become diabetic. In terms of avenues to manage and proceed here, you know, there's some that are close to our world, and that's, you know, pharmacy partnerships, things like alternative strategies, such as the idea of diabetic reversal, which Dr. Brendan Byrne talked about. It's the idea of using intense diet and exercise to really get to a stage where you could potentially reverse the idea of insulin sensitivity and your pancreas pumping out insulin. And then there's this idea of case management approach, but not in the traditional sense, because we have to leverage technology, you know, and digital capabilities to understand how we can do this. And, you know, some techniques can include things like behavior modification through coaching, with an outcome for both education, outcome for diet, and outcome for exercise, and potentially even adherence. And it's through more of a behavior modification type piece. So some considerations, though. You know, if you were to try and intervene early, 5% of claimants is a lot to handle. So a one-size-fits-all model may be costly. There's the other piece where you have to understand what is the time to progression versus return on investment. So, we haven't evaluated how long it takes a diabetic to progress. So, if the horizon to treat or intervene costs more than the horizon for progression, you don't have a good ROI here. So what does that look like? So some work needs to be done there. And then the idea of, what's the role of the payer versus the role of the healthcare system? And I think in this case, there's opportunity for further discussion here, because from a payer point of view, as I showed you, diabetic costs go beyond simply the diabetic category. They can manifest themselves in STD and LTD, hospital stays through amputation or kidney problems, which in turn translate into productivity issues and absenteeism and presenteeism. Just quickly rounding it out, just showing some information here between 2015 and 2019, essentially showing that the eligible is increasing, not in a significant fashion, but it has. And a little bit of information more as a take-home here for our pipeline. Essentially, there's nothing really new coming out at the moment, nothing new that we're seeing. One new medication did just come to market. It's expected to be about $2,500 per individual per year, per claimant per year. In this case, it's an oral. So it's going to take the place of some of the injectables. So you could see some cannibalization of the injectable, but also new entrants where new patients coming to this medication where previously they may not have wanted to, been hesitant or resistant to taking those type of injectables. So summarizing quickly here, diabetes is a complicated, progressive condition. The therapeutic area itself is responsible for about 10% of costs on TELUS book of business, but the population, if you consider everything that they claim for, diabetics are responsible for almost 18% of costs. This patient group happens to take a number of medications on average, and due to the nature of the condition and the idea of multiple medications to get to target. And unfortunately, the more medications a member takes, the less likely they are to take them regularly. So that increases waste. And lastly, there's the idea of managing the patient or the member versus managing the cost. I think we have solutions to manage the cost, but it's not addressing the underlying progression that it seems inevitable without managing the patient and managing the overall condition. So this is it for this first diabetes presentation. I'll just quickly pivot to PLAs, and then we'll open it up for questions here. The PLA should go pretty quick, though. So some general environment dynamics. I would say, looking back, we've seen the large carriers, all looking to perform their own over years. And they've all had a bit of a divergent approach to that. So we saw that as the first trend that came out. And as we're sitting back trying to understand the landscape, there's this idea that it provides a competitive advantage, which I think, is certainly true for a period of time. But of note, we've seen some recent changes that we think are going to start to impact this to a certain degree anyway. The PMPRB changes, which Sean referenced. So what of that is that it's going to offer a lower price for all, both public and private. It's also going to offer a lower price on subsequent molecules into the category. So when a first molecule comes out, that's already at a lower price. When the second molecule in that same category comes out, it's anchored to that first price. So that first price is now the ceiling, so it's even lower. So there's this compounding effect over time that will happen to help reduce costs for both public and private, which is a good thing. So there's less margin to begin with. And then there's this idea that there's PLA transparency. So if a pharma engages in a PLA, they have to report that, and that's considered in establishing the ceiling price. So in this case, we're seeing this downward pressure is what we feel that will reduce pharma's appetite to get into a PLA or product listing agreement to negotiate that lower price because of the consequences as it relates to the bigger public market, but also as it relates to the fact that they have less margin to take that on, and they become less competitive theoretically. The next piece that's interesting is BC and Alberta have really deployed a biosimilar approach, which Sean showed you. It's the idea that they're preferring biosimilars on the formulary, and not simply preferring, but they're removing the innovator, which has some significant cost implications in that case. Ontario is TBD. Like, we thought it was going to come April 1, but I think COVID interrupted that. We still are expecting Ontario to be next on deck. But really, I think what we found was the primary focus started with how do we enable these things, as a market, how do we enable them? But then when we were looking at what's happening since then, this is where 2 and 3 converge to create this downward pressure. So, we have this downward pressure that's being exerted on through the PMPRB changes and the provincial policy changes. And I just want to show you what I mean by that. So, I don't think I'm sharing any secrets here. These are 6 low-hanging fruit targets for PLAs, because the rule of thumb is target those products with a biosimilar or target the innovators where a biosimilar may enter the market. So you see some familiar names here: Lantus, which is in the diabetic category, Basaglar is its biosimilar, Neupogen, Cobaxone, Neulasta. In this case, BC announced that these 3 molecules, they were going to prefer the biosimilar. In Alberta, they announced that these 5 were going to announce that they're going to prefer the biosimilar for over 65. So again, if you had a PLA on these, now it's impacting their viability in those provinces and for those cohorts. In addition to impacting their viability, it's also impacting just the complexity to manage, because now you have to figure out how to resolve for those provinces that are not impacted, but also defensively protect in the event that it spreads to other provinces, such as Ontario. So this is kind of what Sean showed earlier. We are seeing both a direct and indirect result, which is increasing the biosimilar. This is where the government made their change, where they said we're going to prefer the biosimilar in this case to Enbrel. Enbrel, these are new starts. So we see in December, Enbrel had the lowest number of new starts. This is startling, but if you had a PLA on Enbrel, it's now pretty much defunct in BC. Alberta would show something similar in time over 65. Similar here for Remicade. Remicade is the orange. We see it dropping down. We could do a refresh here. Alberta BC changed to add new indications in March. So that would have, as you may be aware, there's only certain indications that were covered for the biosimilar. They've since added more and have looked to switch over for those as well in March. So we're seeing these downward pressures, which is impacting PLA. So really, I think what we're trying to suggest here is, provincial strategies around biosimilars, likely coming to Ontario next and potentially other provinces beyond that, result in a direct change, meaning it's right, if you're not doing a defensive strategy, and the claim is not going to pharmacare in BC as an example, it's coming full freight to your book of business. So that's a problem. But, in that case, you force the direct change to say we want the biosimilar. So that way it goes through pharmacare, which is good, but it impacts your PLA. But then there's this idea of this indirect change, which we would see more in Alberta, where, to Sean's earlier point, prescribing practices normalize, which is the idea that you know, as a physician, I get comfortable prescribing the biosimilar because I'm already doing that for a subsection of my population. So there's a double whammy here to both the direct patient group, but the patient group that surrounds it that the physician is seeing, and likely changing their prescribing habits. So, you know, we expect that carriers are going to be showing defensive strategies, you know, in response to this provincial cost shifting, which is really what it is. And the payers and yourselves here, you know, what you need to be considering is this idea that there's greater complexity to maintain these. So you have to understand what's coming and when it's coming and adjust your agreements accordingly. But also that because of PMPRB, you might need greater volume to deploy and maintain to new molecules. But if the biosimilar market is, that's the third bullet here, if the biosimilar market gets saturated and that they are preferred by default, then that low-hanging fruit PLA is a challenge. So you have to go beyond that. So what does that look like? And you need to get toward a more complex PLA, looking to understand value for money. And how do you do that? So that's it in a nutshell. Lots of changes going on. Distilled it down as best I could here. Happy to answer any questions you may have at this point.
That's great. Thanks very much, Jason. A lot of great information there. Haven't had any questions come through on the chat box, so let me unmute the lines, knowing that we do only have about 5 minutes left for questions at this point, but hopefully if anybody does have any questions, we can address them now. So let me unmute the lines.
La conférence n'est plus en mode présentation.
Okay, does anybody have any questions for Jason?
Yeah, Mike here, Jason. I just want to make sure I understood your indirect impact in using Alberta as the example. So like I'm DC based, so I'm pretty familiar with what PharmaCare here has done. Those slides were very interesting, showing the real impact. So by indirect in a place like Alberta, which to the best of my knowledge, obviously they don't have PharmaCare, but they've got, you know, non-group and all this sort of stuff. Are you suggesting that in Alberta, the indirect impact will be GPs essentially shifting their prescribing in favor of the biosimilars?
Absolutely, and we saw that a few years ago in Ontario when the provincial formulary adopts a biosimilar. It has accelerated the adoption of that biosimilar throughout all prescribing habits. So it would directly impact those over 65 because if you're not shifting, you're not getting that $25 copay in the seniors population, which would be a problem. But the physicians would certainly be becoming more comfortable right now as they see that it's not the sky is falling, oh my gosh, biosimilars are bad. So, you know, it might become more of a coin flip on whether they get the innovator or the biosim.
Okay, good. Thanks.
Any other questions? And if not, and knowing that we do have a hard stop at 4 o'clock, I want to thank Jason, Sean, and all of you who participated today in our session. Just a quick reminder that before we leave, please do take a few seconds to answer the short satisfaction survey that will appear when you close the WebEx application. Also, we will be sending out a video recording of today's webinar and a link to subscribe to TELUS Health's Benefits Hub if you're interested. The Hub will give you access to future webinars, case studies, product information. So there will be a link to that as well if you're interested. If you haven't asked any questions today and you're anything like me, you'll think of something 2 minutes after we're done. My email address, if you can just go to oh, we are on the last slide. There you go. Thanks, Jason. So my email address is on your screen. Please don't hesitate to reach out. Sincerely hope that you found today's session informative. And again, thank you all and Mike for helping me to set this up and allowing for us to be in your part of your quarterly meeting today. All of us here at TELUS Health, thank you again and wish you an excellent day.
Appreciate it, Mike, and to your speakers. Really enjoyed the content. So enjoy the rest of your day and be safe.
Thanks very much, Mike. Take care.